also proposed VE and VF to otolaryngologists for the purpose of adjusting food form. By ingesting 3 times plastic meals orally, the swallowing function improved to the point where the required amount of energy could be secured only by oral injection, and it became possible to withdraw from enteral nutrition supplements and the nasogastric tube could be removed. Nutrition support team proposed the content of appropriate enteral nutritional supplement once a week, and after the start of oral intake, proposed the dietary form, its energy amount, and supplementary nutrition while consulting with other occupations. Also, when was discharged from a hospital, patients have to prepare a paced meal at home, so suggested a cooking method and ingenuity. Changes in body weight and pre-albumin to evaluate the latest nutritional state during hospitalization. From the time of admission, both nutritional state and weight have decreased at the time of discharge. It was thought that this was because it was difficult to secure the nutritional amount of enteral nutritional supplements only by oral intake. Therefore, it was necessary to follow up on weight and nutritional state at regular outpatient visits even after discharge. After discharge, I referred to the dentistry of a university hospital and created a PAP to help the tongue decline function by thickening the maxillar denture. The reconstruction tongue can easily come into contact with the palate, and the delivery of food to the pharynx is improved. The introduction to the university hospital's dentistry was made with reference to the Chiba prefectural swallowing network in order to support patients with dysphagia. We have posted on our website facilities where we can perform exams and treatments. Not only is it easy for patients to access, but an environment is in place that makes it easy for each medical occupation to cooperate. Conclusion: multi-medical occupations cooperation seems to be essential for improving intractable dysphagia, even if swallowing function improves until independence of oral intake. Nutritional state does not necessarily improve accordingly. Therefore, long-term follow-up is considered necessary even after discharge. We have the swallowing network, which provides an environment in which multiple occupations can work together to facilitate interventions in swallowing treatment. Thank you for listening.
Thank you for the presentation, Masaki. So we don't have any comment in the Q&A box yet. So may I ask a question first?
Yeah.
Okay. The patient had experienced 3 head and neck cancer and 3 times surgery over 7 years. And finally, he had a tracheostomy and he was under tube feeding. You showed multidisciplinary approach provided by otolaryngologist, SLP, nutrition support team, and a dentist. The multimodal intervention successfully result in cannula-free. However, improvement of nutritional status wasn't observed during the 100 hospitalization days. Could you explain how much energy did you provide in the case via nasogastric tube?
Yeah. Thank you for your question. Basal energy expenditure is calculated 1,000 kilocalories.
1,600 kilocalorie is administration in consideration of rehabilitation. But by oral intake, finally discharged from the hospital after injecting about 1,400 kilocalories finally.
I see. Do you consider that the body weight could increase if you provided more nutrition during the hospitalization?
Yeah, I think so, but
it's limited?
Yeah, limited.
I see. Oh, we have some questions in the Q&A box. Oh, Professor Sakai want to know about the improvement of sarcopenia was main reason to improvement of dysphagia. Do you think so?
Yeah, I think it considered more many energy for these patients is be successful.
Okay, you wanted to provide more nutrition to recover sarcopenia and sarcopenic dysphagia.
Yeah. I think so.
Okay, so another question from me. We sometimes meet a patient with multiple head and neck cancer. What do you think is important for treating strategy for dysphagia in such patient?
Yeah, okay, thank you for your question. I think it is important to have a skill that not only restore function through rehabilitation, but also respond to morphological change associated with surgery. It is technique for closing the tracheostomy. A technique for dentists who can create a PAP. PAP is parietal augmentation processes or a system for connecting professional swallowing. Yeah, it seems to that connect it is very important.
The concept of this conference, connect it.
Yes.
Yeah. Oh, you developed and used the community-based multidisciplinary network, swallowing network, for transitional care after hospitalization. In this case, is the similar type of network common in Japan? Do you know other swallowing network?
I'm sorry, I don't know any other community.
Very unique. It's very unique approach. I see. So, we have another question from Professor Nagano. Thank you for your presentation. Your title, Dysphagia of Sarcopenia. Please tell us the details of sarcopenic dysphagia. How did you diagnose?
Yeah, we use green criteria. First, his BMI is 60.4. Is sarcopenia.
It seems severe sarcopenia.
Yeah.
And other the strength, weakness of the strength of the swallowing muscles.
Yeah. His swallowing muscle is weakness, and any other operational disorder is there is.
Of course, it contains the weakness of the muscles.
Yes.
Okay, Masaki, thank you for the presentation and replying the answer.
Thank you.
So let's move to the next speaker. Thank you very much, Masaki.
Thank you very much.
The next speaker is Professor Jimin Tang from China. The title of this paper is Effects of High Energy Density Enteral Nutrition on Aspiration Pneumonia in Dysphagia patients. So, Jimin, are you ready?
Okay.
Okay, over to you.
Yeah, fine. Okay, please, playing. Hello, everyone. Today, I would like to talk about effects of high energy density enteral nutrition on aspiration pneumonia in dysphagia patients. We have no slide to presentation. When substance from oral or from the stomach aspiration to the airway, it may cause pneumonia. So this pneumonia was defined as aspiration pneumonia. About 13% of nursing home patients have aspiration pneumonia. 1/3 of the total elderly pneumonia deaths caused by aspiration pneumonia. Dysphagia is the most reason of the aspiration pneumonia, and half of the patients with dysphagia may have aspiration, and 1/3 of them developed into pneumonias. In patients with dysphagia, it will have high risk of aspiration and US dysfunction and regurgitation. This may lead a aspiration pneumonia, and dysphagia also often has insufficient food intake. This may cause a malnutrition and lead a immunodeficiencies, which obstructed aspiration pneumonia recovery. So, how to make a nutrition treatment for patients with dysphagia and aspiration pneumonia? Previous studies show that high energy density enteral nutrition can decrease mortality and increase calorie intake. And early application of high energy density enteral nutrition improve the energy supply for patients with severe brain injury and reduce the incidence of hospital infection. So our study was to investigate the effects of high energy density enteral nutrition on nutrition and pneumonia outcomes in dysphagia patients with aspiration pneumonia. All patients was from our rehabilitation medicine department. The inclusion criteria as follows: dysphagia, aspiration pneumonia, and high risk of nutrition, and the patients can accept this study. A total of 32 cases involved in this study, and 3 cases withdrew due to the medical changes during the study. We divided the patients in 2 groups: high energy density group and a control group. We made a assessment at baseline and after 3 weeks intervention. All patients received regulation treatment. In high energy density group, we're using commercial enteral nutrition with 1.5 to 2 kcal per milliliter energy density. In control group, we use normal diet or conventional enteral nutrition, and the energy density is below 1 kcal milliliter. The feeding method was nasogastric tube or oral plus nasogastric tube supplement. The total energy calculation as follows. However, when BMI less than 18.5 or more than 25, we use the adjusted body weight to calculate the total energy. Here is the example of our nutrition plan for one patient. We defined the time and EN and the volume and feeding method in our plan. We assessed the nutrition outcomes as follows and assessed the pneumonia infection outcomes as follows. So after 3 weeks treatment, the BMI of the high energy density group was improved significantly. Also, is better than the control group, and the serum pre-albumin also improved in high energy density group, and is better than that of control group after 3 weeks intervention. The hemoglobin also is improved in high energy density group and is better than control group after 3 weeks. However, no significant difference was found in serum albumin both in 2 groups. Also, there were no significant differences of gastrointestinal intolerance between 2 groups. The death of antibiotic use of high energy density group was significantly lower, shorter than that of control group. And the white blood cell count and the neutrophil ratio is lower in high energy density group than that of control group. So we consider the mechanism as follows. The firstly, the high energy density group, the high energy density enteral nutrition can reduce overall food intake volume and reduce stomach residue, shorten gastric emptying time, and reduce the risk of reflux, especially with movements or postural changes during the exercise. Finally, ensure the adequate nutrition. We have some limitations. The first is the sample also is small, and the number of outcome is limited. Conclusion. Our study indicated that high energy density enteral nutrition can improve the outcome of nutrition and aspiration pneumonia in patients with dysphagia. Thank you.
Thank you very much, Jimin. So please post your comment, audience. Meanwhile, I'd like to ask you a question. Okay, the study found that high energy density enteral nutrition led to improvement of nutritional status and shortened length of the days of antibiotic use. So I'd like to confirm the design of the study. Was the study a randomized control trial?
Yes, we use a random.
Could you explain background characteristics of the studied patient regarding age, etiology of dysphagia, or ADL, activity of daily living, or severity of pneumonia, etc.? Could you explain?
Yeah, our study, almost the patients was the stroke patients. So there's almost 1/3 of the patients with tracheostomy. So the ADR is the basal index is lower. Almost the patients just on the bed cannot walk.
Okay. Thank you very much. So we don't have any comments. During 3-time intervention, three weeks intervention.
Yes, yes.
Patient in the high energy density group could achieve weight gain.
Yeah, yes.
Find difference in terms of provided amount of nutrition between groups. Do you have any difference? Nutrition?
You mean
amount of energy. Do you find any difference in terms of provided amount of nutrition? The same nutrition in both group?
The same nutrition? You mean the total energy we provide to the patients?
Yeah. The energy.
Actually, we want to provide the same energy to these two groups. However, in high energy density group, we can provide the goal of the total energy, but in the control group, we try to provide. However, I think most of patients cannot achieve their goal energy because the low density energy, and we cannot provide more volume to the patients because we want to prevent the reflex of the patients because they have the pneumonia.
Okay. Professor Sakai want to know, what was your primary outcome? What was your primary outcome? How did you determine the sample size? So you want to know two questions.
Yeah, this is
outcome.
Yeah, it's very nice questions. So my primary outcome is the I think two part of the primary outcomes. One is the nutrition outcome, is the BMI, and the next is the pneumonia infection outcomes. So I think is the antibiotic the strategy they use. So I think this is the two primary outcomes, and the sample size. We start a small study before this random design studies. So we use this data to calculate primary to calculate the sample size.
Okay, thank you very much, Min. So we are running short of time. So
thank you.
Do you mind moving on to the next speaker? Okay. Thank you.
Okay, thank you very much.
Thank you very much.
Okay, everyone.
So we welcome the third speaker,